Good morning, everyone. First and foremost, tremendous heartfelt gratitude to the organizers of Power of Storytelling Conference. I'm so honored to be here. Christian and all of his colleagues worked extremely hard to put this together, so I'm honored for the generous invitation. You know, I one of my favorite reasons for coming to events like this is that it brings together fascinating people from all over the world. So, you probably know that right now we're in Bucharest. I probably don't have to show you that on a map, but and when I think of this incredible city with its rich history, I think of the Romanian Athenaeum, which is just down the street. I think about a little further up from here, the Citadel, the Vlad the Impaler Castle, and remarkable architecture. So while right now I live and work in New York City, I moved there 3 years ago. That's not where I'm originally from. I was actually born and raised in Toronto, Canada. And sometimes stereotypes exist for a reason. So now that I told you that I'm Canadian, I'm from Toronto, what sport would you say that I love? Yes, exactly. Hockey, Toronto Maple Leafs. Woohoo! But I got to tell you, my Toronto Maple Leafs have not done very well for the past decade. But a sports team that has done well, if you follow, it's the Toronto Raptors basketball. We won the championship. Woohoo! But you have your lovely, beautiful architecture with a very historic, beautiful, stunning architecture. We don't have architecture quite that old, but we in Toronto have the CN Tower. That's what we're quite famous for. So again, thank you again. I know there are people from all over parts of this map that are here. So allow me to introduce you to somebody who's very special to me. I first met Brian when I was a primary care doctor to Boston's homeless population. Frustrated, depressed, and struggling with severe neck, shoulder, and back pain, Brian just had enough. He said, "Dr. Roy, I just can't take it anymore." In addition to Brian's chronic medical and psychiatric issues, he had also just lost custody of his son and lost his job, both of which drove him into deeper depression. Ashamed but desperate, Brian started to use heroin to numb his pain and suffering, and he just couldn't stop. Sadly, Brian's story is not unique. It turns out that the leading cause of death amongst Boston's homeless population was drug overdose. And when that data came out in 2013, it completely transformed the way that I provided care. And I'll share more of my journey and Brian's as we go along. I must confess, when I saw the list of highly impressive speakers at this conference, many of whom are professional journalists and writers and artists, I thought, oh my God, did the organizers know that I'm a medical doctor? Not a professional, writer and storyteller. Did they make a mistake inviting me? Shh, don't tell them. I snuck in. But it actually turns out, if you look at history, even current day, there's actually a long tradition of physicians as storytellers. And dating back to Sir Arthur Conan Doyle, Sherlock Holmes, Anton Chekhov, Oliver Sacks. And more recently, a string of incredibly talented female doctor writers. Dr. Danielle Ofri works at New York University and Bellevue Hospital. Dr. Lisa Sanders now works at Yale Medical School, but she has a regular column in the New York Times called Diagnosis, which was the basis for the television show House, for which she was a medical consultant. One of my mentors, Dr. Suzanne Coven at Massachusetts General Hospital and Harvard Medical School, who writes a regular column for the Boston Globe. And then Dr. Abraham Verghese, Dr. Siddhartha Mukherjee from Emperor of All Maladies, Atul Gawande. And then I thought, well, there's quite the string of Indian male doctor storytellers, and I thought, I think it's time we need more Indian female doctor storytellers. Who knows, maybe? There's my Toronto Maple Leaf shirt. I'm so biased. Anyway, so speaking of stories, let me start from the beginning. So on day one of medical school, we learned two key lessons. Lesson number one, always listen to your patients. And then lesson number two, your patient will be your best teacher. Obviously, both points are related. But then the next thing you know, fast forward weeks, months, and years after medical school, after learning these key lessons, a doctor's life becomes consumed by Q3 overnight call in the intensive care unit, pagers buzzing at 2 a.m, pharmacists requesting medication refills, nurses calling for whatever reasons, meetings with the family members of your patients, electronic medical records for documentation and billing, and the pressure to see more and more patients, resulting in mere 10-minute visits with each patient. And then you slowly begin to realize that those important key lessons about listening to your patient's stories slowly fade away. And this became evident, this loss of this vital skill of listening to my patient's stories, that loss became evident when I started caring for patients like Robert. Robert is a U.S. Marine Corps veteran whose severe alcohol use disorder and depression resulted in living on the streets and homelessness for over a decade. Robert, in the beginning, he came to see me in clinic, and I had referred him to counselors and case managers and psychiatrists. And he did okay for a bit. He stopped drinking, and he was slowly getting his life back in order. But then he relapsed. He started drinking again, and there was at the height of his drinking, he had presented to the emergency department nearly every week for like half a year. Just think about that for a moment. Most of us, myself included, may present to an emergency department once or twice over the course of a lifetime. Robert presented to an emergency department 20 times in 6 months. That tells me just how much pain and suffering this one individual had that went almost completely underaddressed. And eventually he started to come back to see me after multiple missed appointments. And when he did, boy, did I voice my frustration. I said to him, Robert, I've connected you to counselors, to psychiatrists, to all these health professionals and specialists, and I continue to refill your medications, none of which you pick up. All these appointments with these healthcare professionals you've missed because you continue to drink. And by the way, all of those emergency department visits were all related to alcohol intoxication. I said, you are not taking the meds I prescribed. I've referred you to all of these medical professionals and psychiatrists and therapists, and you're missing them all. You keep drinking. I don't understand. So Robert just sat there. He looked down, shaking his head, riddled with guilt and shame, and he said, I know, Dr. Roy. I'm trying. I know I shouldn't drink anymore. I'm trying to stop. I just don't know how. So it's difficult for me to recollect this story. Because when I think back and I think of the words, I clearly I clearly forgot my role as a physician, my role and my responsibility as a physician and a caregiver. Instead, the comments that I made to him were filled with judgment, with stigma. My tone, the words, everything that I said, and the way that I said it was just so judgmental. And you could, if you were there, you could see it in him. He was so remorseful, with profound remorse. He was apologizing to me. And I think of not just that story, but many stories like that, many examples of where I spoke with those words and with that tone, with patience, like Robert. But, and by the way, when I think back to all the comments that I made, if you think about it, I made it all about me, right? I was saying, look at all the work I've done. I did this for you. I'm doing all this work, right? But that's not what my role is, right? That's not what a physician, a caregiver, a health care professional is supposed to do. It's not about you. At that moment, you have a relationship, a very intimate, trusting relationship, which, by the way, you need to build. I learned I need to build over time, and I clearly lost that sense, that oath that I took. But I should be honest in that I also, over time, learned about the gaps in my own knowledge. I forgot to really realize that Robert's primary illness was his addiction to alcohol. And the sad reality is that most, in fact, almost all doctors, most do not learn about addiction during medical school or residency, myself included. And I actually, in fact, everything that I'm saying to you now has been from on-the-job training, on-the-job learning. And when that data came out in 2013, a year into my job, showing that the leading cause of death amongst my patients was drug overdose, I devoted considerable amount of time and effort to educate myself, to listen to experts in the field, to listen to patients and their stories, and what the addiction to the substances was doing to their lives. I became board certified in addiction medicine, as Nicoletta mentioned, all in an effort to better understand what my patients were going through. So one of the key lessons that I learned was that addiction is in fact a chronic medical disease of the brain, a relapsing and remitting disease that causes compulsive drug seeking and use despite harm to the person using and to those around him or her. And while the initial, it is not a sign of moral weakness or failure. And while the initial decision to use may be voluntary, the changes that happen over time impair that person's ability to adjust his or her drug use. In medical school, as I'm sure in, say, law school or journalism school and business school, you learn, you get bombarded with information. And so in med school, we come up with mnemonics, simple ways to remember things. So with addiction, I learned about the 4 C's. So, and this is a really simple way to understand the key components of addiction. So it includes impaired control over drug use, compulsive use, continued use despite harm, and cravings. Think about cravings as the primary symptom when it comes to addiction. So for instance, if somebody was having, say, a heart attack, their primary symptom might be chest pain. Or if somebody has chronic bronchitis, emphysema, COPD, it might be shortness of breath. But in addiction, the primary symptom is cravings, and it's that symptom that drives all of their behavior. I, over time, learned that the root causes of addiction aren't what I initially thought. I think when we think of addiction, we think of drugs, we think of tobacco. I don't think this point will work here. We think of like cigarettes, we think of alcohol, substances, other drugs like cocaine, heroin, fentanyl. But there's also behaviors to which we can become addicted. Behaviors like gambling, smartphones. I have 3 of those devices. Bread, Oprah. Who doesn't love bread, right? Coffee. How many people have already had 1, 3 cups, right? And then, of course, my personal vice. Yes, I have a donut up there, not because I'm just Canadian, but I just love all chocolates. And the people I had dinner with last night can attest that I certainly love my desserts. But I'm going to make the case for you, and this is what I've learned, is that these individual substances and behaviors aren't the true cause of addiction. But in most cases, like with Robert and with my patient Brian, the true causes often are stressful, difficult, challenging, traumatizing experiences, unemployment, illness in the family, loss of a loved one, divorce, physical, sexual, verbal abuse. And all of these, and in the case of, say, my patient Brian, who lost custody of his child, had severe physical and mental pain. All of these stressful, difficult, traumatizing experiences, either one individually or a buildup, leads to complex emotions such as isolation, grief, frustration, anger. Wow, that was traumatizing. I'm just hoping we don't have to evacuate right now if this is a fire. I will try to go on. Oh, okay. I think it stopped. Okay. Everyone, take a deep breath. We're good, right? If anyone's having chest pain, let me know. I am a doctor. Please don't have a heart attack, though. That was not planned. No. That was not planned at all. So apologize for the mini little disruption, but thank you for bearing with me. But the case I'm going to make is that these underlying traumatic experiences create these complex emotions: isolation, grief, frustration, anger. And when we're not in an environment where we can address those emotions in a way that's healthy, then we often self-medicate with drugs, with alcohol. And by the way, I'm not saying that everyone who experiences something that's stressful and traumatizing automatically develops addiction. I'm not saying that. However, what I'm saying is that almost every one of my patients who I've taken care of who has addiction has some type of exposure to something that was traumatizing or stressful. There is a very strong correlation. So, I learned about the brain, and it turns out that the before I understood how addiction worked, and I blamed patients like Brian and Robert for not taking responsibility. By listening to their stories and learning about the brain biology of addiction, I had a far better understanding of how drugs and alcohol were impairing key parts of their brain that controlled emotions, cravings, decision-making. So, and by the way, it turns out that the neurobiology of addiction is really well established. But these are 3 parts of the brain that I focus my attention on. And one is the basal ganglia that's responsible for motivation, reward, pleasure. The dopamine neurotransmitter is involved in, it's the pleasure neurotransmitter. It's responsible for habits and behaviors. Then there's the amygdala, which is responsible for fight or flight. It's the sympathetic nervous system that's involved with, like if you see a grizzly bear coming, you're gonna flight, right? Or you can fight it. I personally will be flighting and running away. But the amygdala is also associated with negative emotions like anxiety and irritability. And then there's this third part of the brain called the prefrontal cortex, which is the front part of the brain here that's responsible for complex decision making. So think about before you came here this morning, you probably turned off your alarm clock, picked out what you were going to wear, might have had something to eat, might have checked your phone for any texts or emails, and you're probably thinking, yeah, Lippy, that's common sense. I do that off the back of my hand. But think about all the decisions that your brain made in the matter of 1 to 2 minutes. Now try to making those decisions with substances on board, drugs or alcohol. And these are the 3 stages. The first stage is, you consume something that's intoxicating and you begin to experience pleasurable, rewarding effects. Think about you had maybe 1 or 2 glasses of wine over dinner, feel a slight buzz, right? And then the second stage, a person experiences a negative emotional state when you're not using. I sometimes think about my mother when she hasn't had that first or second cup of coffee. She feels a little irritable, right? The third stage, a person seeks a substance after a period of abstinence. I think about my patient Robert, who went quite some time without drinking, but then he relapsed. But that's actually, turns out that's very, very common and expected in addiction. It's not a failure. And frankly, I also learned that relapse rates actually are sometimes even higher in other chronic illnesses like asthma and high blood pressure. We just don't think of people with those other chronic illnesses as relapsing like we do with addiction. So while I was in the context of learning about taking care of patients with, I was working in a homeless shelter, taking in homeless shelter clinics, caring for patients. In the wider context, this is what was happening in the rest of the United States. So this is, in 1999, the landscape of the country, the red parts indicating the number of overdose deaths per 100,000. So small smattering back in 1999. And then a mere 15 years later, this is the landscape of the country. So, but I'm sad to tell you, ladies and gentlemen, that was way back in 2014, a whole 5 years ago. Today, easily 70% of this map would be a deep red. Again, the color indicating lives lost. And according to the CDC, we've had 72,000 deaths related to drugs in 2017 in the United States, mostly driven by opioids. So as topical and as newsworthy as opioids like heroin and fentanyl are, and justifiably because people are actively dying, I learned actually that alcohol has even far-reaching effects and was far more pervasive in terms of its impact on my patients and society in general. Excessive alcohol consumption accounts for 1 in 10 deaths in working age US adults. I learned that alcohol amongst high-risk drinking college students, university students, over 1,500 deaths, 700,000 assaults, almost 100,000 sexual assaults and date rapes, 5 million drunk driving accidents, and almost 40% engage in binge drinking. And then here locally, it turns out that Romanian males are the world's heaviest drinkers with an average of 8 drinks per day. And Romania is not alone here. This is alcohol is a pervasive problem that crosses cultural, ethnic, gender barriers. According to the World Health Organization, globally, alcohol results in 3 million deaths each year, or in other words, 5% of all deaths. I learned that alcohol kills far more people than opioids. And do you guys know what actually kills more people than alcohol and opioids combined? Which substance? Oh, somebody said sugar, close, but in terms of cigarettes, tobacco, exactly. So when I started working at Rikers Island, the second largest jail complex in the United States, I learned some critical lessons. One was that if you weren't traumatized before you got to jail, you most certainly will be once you get there, no matter what side of the bar you're on. Both correction officers and people behind bars often are from the same neighborhoods. I also learned that correctional medicine is addiction medicine. Correctional facilities are the largest addiction treatment facilities and mental health facilities. It says a lot, actually, about the failure of every sector of our society, from our medical system, government, education, law enforcement. A third lesson I learned is that the vast majority of people that are behind bars and have addiction, those addictions go completely untreated. And by the way, those if you have opioid use disorder, opiate addiction, some of those uncomfortable withdrawal symptoms include a constellation of symptoms such as nausea, vomiting, diarrhea, severe sweats, body aches, irritability, anxiety, and increased suicidal thoughts. Vast majority of people experience this completely cold turkey, untreated, even though we have medications to treat this. And the other key lesson that I learned is that over 50% of people behind bars experience a substance use disorder. Vast majority of people with this chronic illness, this chronic disease of the brain, go untreated. But perhaps the most significant lesson that I've learned from caring for patients with addiction is the role of stigma. Stigma is any type of attribute or behavior or condition that is socially discrediting. Of the 23 million Americans with substance use disorder, only 10% access treatment. 10%. I'm going to come back to that number and related to other medical conditions. Stigma is a major barrier to care. According to the World Health Organization, drug addiction is the #1 most stigmatized social problem. Not health problem, social problem. It's more stigmatized than poverty, homelessness, incarceration, and I think mental illness and alcohol are like number 3 and 4. But right now, I'd like to share with all of you a very simple and effective way in which we can all reduce stigma, and that is by changing our vocabulary. Words matter, and I don't think I need to convince this audience who's coming to a storytelling conference about the power of the words we speak. So I learned, after reading a lot of incredible scientific literature and hearing other experts speak, that when we use stigmatizing, punitive, tough language, such as substance abuse, drug abuser, war on drugs, your urine is dirty, you're a junkie, cokehead, alcoholic, druggie. We have no shortage of derogatory terms that we use to label people with addiction. So when we use these types of phrases and hear them, the effect on patients or people with addiction is that they are more likely to perceive discrimination and they're less likely to seek help. But it turns out that these types of words and phrases also affect healthcare professionals like me. By the way, I used to use all of these phrases. I no longer do because now I see the harm that it causes. Amongst healthcare professionals, they have less regard for patients with addiction. They label people with addiction as being less motivated, violent, manipulative. And we spend shorter time in clinic with people with addiction. All of this adds up to suboptimal care. But instead, studies show that when we instead use compassionate, less judgmental language, such as a person with a substance use issue or a person with substance use disorders, or your urine is positive. When we use that type of language, people feel less judged, more respected. It improves the therapeutic relationship between the doctor and patient, or caregiver and patient. And the key point here is that people with addiction are more likely to seek care. So then I thought about this. I thought, well, again, one of the many lessons that I learned, that they don't explicitly say this in textbooks. So, how I said people with addiction are often, if they test positive for, say, cocaine or alcohol, heroin, they're told, oh, your urine is still dirty, right? Which by extension means that they are dirty. But then when my patients with diabetes come in with a blood sugar of 800, I don't say, oh, well, Mr. Johnson, Mr. Stefanescu, for more local reference. I don't say, oh, your urine is dirty with sugar because you abused apple strudel de mer last night. In that case, I abused Haagen-Dazs ice cream last night, right? Right? We don't do that. I've never done that. I have never said that to a single patient of mine with diabetes. But I've told people with cocaine addiction, oh, your urine is still dirty. I've gone through a lot of changes because I learned that my behavior was actually harming my patients. So these are things that I've come to, have you heard that expression? Sometimes it's harder to unlearn something than to learn it. Well, I've worked really hard to try to unlearn some of the damaging things that I used to say. So another thing that I've learned in doing this work is that caring for people with a lot of these complex medical, psychosocial issues can be challenging, can be stressful, and can be very demanding. Not just for me, but the people I work with, nurses, counselors, therapists, administrative staff, receptionists who are sometimes the front lines who see people coming into the clinic. And of course, in all the talks and conferences I've spoken at, the audience members, everyone has stress in their lives, right? Family, work, school. Stress is pervasive. And so the point that I'm getting at is that I've come to learn some key skills in self-care, which I'd like to just share with you. And it's really transformed the way that I deal with the stress in my life. And then I share with my patients too, by the way. So I actually have incorporated mindful practice into my life. I meditate every morning. I do yoga once a week. I write in a gratitude journal by my nightstand. Studies show that when people who express gratitude are happier, and happier people live longer. I also I try to get enough sleep, but they say 7 to 9 hours. I know many of you are like, there's no way I'm going to get 9 hours. But studies have shown that poor sleep is associated with every possible chronic illness, including dementia. I try to eat regularly and healthy, and it doesn't have to be 3 big meals, but even 4 to 5 small meals throughout the day. Exercise, you don't have to run a marathon. Even 20 minutes, 3-4 times a week has health benefits. Drinking plenty of fluids, and just do what you enjoy. I go out to see movies, meet up for dinner with friends, exercise, museums, art galleries. And sometimes it's okay to just do nothing. There are so many days I just come home and I just plop on my sofa and just lie there, and that's totally okay. And last, but most certainly not least, I know this is a group of very highly motivated, ambitious, smart people. Ask for help. There is no shame in this. It'll make your life easier, and probably the people around you as well. So then what happened to my patient, Brian? So the first thing I said to him was I thanked him for taking the time and effort to come see me and share his story. I then said that we were going to work together to get you the care that you need and you deserve. I connected him to psychiatry, orthopedic surgery to help with the pain, case management, and social workers to help with the job and housing. Over time, after months and months and months of hard work and resilience on Brian's behalf, attending multiple medical appointments and counseling group sessions, while navigating the challenges of homeless life, today, years later, Brian, oh, sorry, I also started on buprenorphine for opioid use disorder. So today, after doing all these things, Brian now has an apartment. He has a relationship with his son. He is now in long-term recovery, I'm very proud to say. In essence, Brian's life today has a sense of purpose. And by the way, if you're interested, you can learn more about Brian's story and my journey as well in a documentary short called The Faces of Addiction that was produced by Refinery 29. I think it's like just 20 minutes long, and you can find it online. And in fact, this photograph was taken from the documentary. And last but most certainly not least, my love of storytelling started with my parents who emigrated from India to Canada over 40 years ago, and they shared their stories with me. They continue to share their stories of my mother growing up in New Delhi, my father growing up in West Bengal and Calcutta, and how he studied at the first ever technical school college in Bombay, and how he took an 11-day journey by boat to go to Germany to be an intern, work in internships for years, and then went to England. And then he spent 20 years traveling and exploring Europe. And how they both he went back to India, got married to my mom, and they both came to Canada. And all the stories of joy and hardship in moving to a country where they didn't know a soul. And then learning, and then me and my brother learning, being born and raised in Toronto, and learning about Indian culture and temples, and Lucia was talking about samsara and like Hinduism and goddesses Kali and Durga, and all these amazing stories. All started with my mom and dad, who are in Toronto right now. So thanks, Mom, Baba. And on that note, I thank each and every one of you for taking the time and effort to listen to my story. Thank you very much.